Antimicrobial resistance is one of the most intriguing problems that we come across in the modern medicine, and it will continue to grow. We will have to fight with resistance of antibiotics in the future. So I'm just going to give you a glimpse of idea about what we can do as healthcare professionals. Importantly, how can we contribute as nurses? So this is, we are the Sri Lankan College of Internal Medicine, and there's an expert committee of infectious diseases that we are prepared this presentation and also the content. So what are the things that are important to know about antibiotic chart related knowledge? So first thing, be mindful about antimicrobial resistance in your clinical practice. How can we be more mindful than we are at the moment? How to treat antibiotics as a special group of medication. We all should be aware about this. What are the pearls of the antimicrobial chart? And we should be equipped with this knowledge to use it for better cause than today. What is aware classification and what is antibiotic stewardship or antimicrobial stewardship? So first to begin with, there's an elephant in the room. There's a big problem in our ward. Sometimes we tend to neglect this. Although there's a big problem, we concentrate on other problems, neglecting antimicrobial resistance, not seeing the elephant in the room. So we are aware that antibiotics are getting resistance, but are we doing enough? Are we doing enough to combat antimicrobial resistance in our ward? Because antibiotic is not like any other medication that we see. Antibiotic is not like metformin. Antibiotic is not like enalapril or any other drug that you come across. Because the more that we use antibiotic, the more it creates resistance. So we have to safeguard our antibiotics for our future generations. And each prescription has a community impact. Although we give it to an individual, it causes resistance, and resistance will be the impact will be on the community, whole community, not on that specific individual only. And the main problem is antimicrobial resistance is expanding and deaths are increasing in a rapid rate. If you can see in 2050, you can see 10 million deaths going to happen due to antimicrobial resistance. And that is going to surpass the cancer deaths that we are going to have today, like 8 million cancer deaths in 2019. It's going to go way beyond that. And if you look at the continents of the world that antimicrobial resistance will become a problem, Africa and Asia is going to have, you can look at those big pyramids, you can see Asia is going to have a massive number of antimicrobial resistant related deaths, and also Sri Lanka is part of this. The main problem is antibiotic discovery is disappointing. There's limited amount of options that we can use. And the expensive options of antibiotics that we have, combination antibiotics, it will be very difficult for us to afford these antibiotics given the economic situation of the country. So we have to safeguard what we have at the moment. So there is no way other than that, fight AMR together. Because AMR affects everyone. It can spread from one person to the other. We fear a patient who is having chicken pox that it will contract us. But do we have the same fear when we come across a patient who is having an MRSA or ESBL or multi-drug resistant bacteria? So we should come together as doctors, nurses, and other healthcare professionals to fight antibiotic resistance together. So what about how can we be mindful about AMR in our ward setting? So if we look at these facts and figures in our ward, try to mark the numbers of these indices in the ward every day. Percentage of people who are in meropenem in the ward. Number of cases who having hospital-acquired infections. Number of cases having antimicrobial resistant diarrheas. How much of drug-resistant culture reports that you see, MRSA, ESBL, multi-drug resistant, any other bacteria, and how many are dying despite giving broad-spectrum antibiotics? If we have a figure, 2 out of 50, 3 out of 50, or whatever it is, whatever the figure, if we count these on daily basis, you will get a proper idea how much of antimicrobial resistance exists in our ward at the moment. So that's why we need to treat antibiotics as a special medication, unlike comparing with the other medication that we have. So initially we used to mark antibiotics in red, isn't it? But now we have a separate antibiotic chart, which is introduced by the College of Microbiology, and there's a separate number given for H1338, and this is the cornerstone of saving antibiotics, or saving antibiotics, in other words, antimicrobial stewardship. So there's a dedicated antibiotic chart. These are the components that you will see in the antibiotic chart: demographic details, antibiotic allergy, indication for antibiotic, appropriate cultures has been sent or not, what is the antibiotic type, dose, route, and the frequency of antibiotics. So those can be filled by a doctor or a nurse, and an antibiotic review should be done by a doctor. So what are the pearls of the antibiotic chart? What should we know? So first thing is the demographic details. We have the patient identification details is very important, because as healthcare providers, we have a primary responsibility for patient identity. Ideally, it says there should be two identifiers, there should be two identified to recognize a patient: a name, date of birth, right? It should not be the bed number. So ideally in other countries, it has been standardized. They have a wristband, and maybe having a code that can be scanned as well. So we don't have that at the moment, but we have to have two personal identifiers. Second thing, the antibiotic allergy. So what is it important? So there are minor antibiotic allergies and major antibiotic allergies. We should all be aware about this. So minor antibiotic allergies, there can be local urticaria, itching, and major antibiotic allergies are anaphylaxis, swelling of the throat and the lips, and Stevens-Johnson's reactions. So we have to have an idea about this to document what is the specific antibiotic allergy that the patient is having. So if there's as an example, if there's a minor allergy to penicillin antibiotic, we can use cephalosporins in those patients. If there's a major allergy to penicillin or amoxicillin, so although it says only to penicillin and amoxicillin, we cannot use flucloxacillin, we cannot use comoxiclav, we cannot use piperacillin tazobactam, because they are in the same group of antibiotics called beta-lactams. And sometimes there can be uncertain allergies in these patients. Like some people might say, okay, the patient might be having a headache after getting an antibiotic, maybe having a bit of diarrhea after antibiotics. So that might not be allergy. So in that case, we should tell the doctors there's a thing called antibiotic delabeling. You can take out the allergy after carefully assessing this. So we must highlight the doctors that this might not be a true allergy. Next section is indication for the antibiotic. This is a very important thing, because one of the most important things that we come across in the chart, because depending on the infection, the antibiotic differs. So as an example, if it is cellulitis, we give flucloxacillin. If it is a pneumonia, comoxiclav and clarithromycin. If it is a meningitis, it's ceftriaxone. So we have to identify the infection to give the appropriate or best antibiotic for that specific infection. So it's important to have a diagnosis or the source of the infection to begin with. Sometimes infection cannot be very clear. So in that case, we have to actively look for the type of infection that we are having. The next part is documentation of the cultures. Sorry, the box has been gone off the chart. So this is one of the most important things, because from this we can identify what is the specific antibiotic that we can give later. So one main fact is sending blood cultures first. Always be mindful. In a patient who is critically ill, very severe infection, when you are giving an antibiotic, please check whether antibiotic blood cultures has been sent, or sputum culture or urine culture has been sent before starting antibiotics. And also another fact is, we have sent the cultures, you have to trace it also. After 48 to 72 hours, we have traced the blood culture or any other culture. So from that report that we get, we can refine or we can optimize the antibiotic that we are going to give. The next factor is, what about learning these terms? What is antibiotic escalation? What is antibiotic de-escalation? I think we all should be aware about the terminology that we use when we are prescribing an antibiotic. So if a patient is critically ill, patient is septic shock, if a patient is immunosuppressed, we are using broad spectrum antibiotic, the antibiotics which have a larger cover for the bacteria. Narrow spectrum means have a narrow cover, the lesser cover for bacteria. So if the patient is very ill, we can start with broader spectrum antibiotics, meropenem or piperacillin tazobactam, that's completely fine. So, but if the patient does not have a complex infection, usually cellulitis, pneumonia, or any other infection, and if the patient is got better, usually what we give is 7 to 10 days of IV intravenous plus oral antibiotics is enough. So if it is going beyond that, I think there's a problem. So either the infection is not under control, or either it can be we are giving antibiotics unnecessary for a long time as well. That's why antibiotic review is very important. But if we feel that if there is no infection, if there's viral infection and does not need antibacterial antibiotics, then we have to review antibiotics and stop these antibiotics if it is necessary. Because remember, the more that we give antibiotics unnecessarily, the more that we are inducing antimicrobial resistance. That is an important message. So when we don't need antibiotics anymore, we have to stop antibiotics. Better, we have to de-escalate the antibiotics from broader spectrum to a narrow spectrum antibiotic, which is equally effective to the broad spectrum antibiotic. As an example, if we start meropenem for a patient with cellulitis, we get the cultures as Staph aureus, and we can de-escalate our antibiotic to flucloxacillin, which is a great drug again. It is not inferior to the broad spectrum antibiotic. Okay, so learn the term de-escalation and what is that. So this is an example, 50-year-old admitted with pyelonephritis and had a recent admission due to same illness, started on IV meropenem, urine cultures came as follows, and you can see in the cultures, although we are giving meropenem, it's sensitive amoxicillin clavulanic acid, which is co-amoxiclav as well. So the patient is getting better, but the patient is still having fever. But of course, the culture says that it is sensitive to co-amoxiclav. So you can de-escalate from meropenem to co-amoxiclav at this time. And there's another case. A 45-year-old admitted with septic shock and started on IV meropenem. Now, after antibiotic, the patient is feeling better off inotropic support. The fever is gone for 24 hours. The CRP is reducing, white cell count reducing. The patient is start eating and drinking, and the urine culture grows an E. coli back again. It's again sensitive to co-amoxiclav. So rather than de-escalating to we can of course de-escalate in this patient, and also we can switch the patient to oral antibiotic here rather than giving IV. Because when you switch to oral antibiotic, the patient can go home, isn't it? If you continue IV, the patient will have to stay longer in the hospital. The patient has got better. Culture says the co-amoxiclav will work fine. So we switch to an oral antibiotic, which is called an IV to oral switch. So we switch from IV to oral as well and send the patient home, safeguarding the patient. So next section is the drug, route, dose, and the dosing. So here is the section that you must enter all this detail. So why is it important? For antibiotics to kill bacteria effectively, the appropriate antibiotic is important. You have to give the appropriate antibiotic for the appropriate infection. You cannot use any antibiotic for any infection. And correct dose is important. So measuring the patient's weight is sometimes important. And the correct route is important. If the patient is ill, you have to give intravenously initially, right? And also frequency is important. Flucloxacillin should be given every 6 hours. We cannot give twice daily or 3 times daily. And we have to adjust it according to the renal functions. So all these factors are very important for the optimal drug delivery to safeguard the patient who is having an active infection. Other than that, in the chart, we have to indicate whether it is prophylactic antibiotic, empiric antibiotic, or specific antibiotic. That is also important. There's a place that we can indicate that in the chart. And also next step is finalizing the duration of antibiotic. This is very important because usually in a conventional infection that we see, IV 7 days, maximum 10 days is enough. IV to oral, both antibiotics included, 7 days is usually enough, maximum 10 days, right? So encourage the doctors to do this antibiotic review. So in this chart, you can see there's a column called antibiotic review. After day 2, D2, we can see review, RV. And in day 2 to 3, there's one review. After day 7, there is one review. After day 10, there is one review. So we must encourage the doctors to do this antibiotic review, and we can continue our antibiotics further. So, because the problem is there is more and more evidence that shorter courses of antibiotics are working equally better than the longer courses. Initially, sometimes we tend to give like 14 days for a pyelonephritis. But now we are only giving 7 days of antibiotics for pyelonephritis. The antibiotic courses are getting prolonged to reduce antimicrobial resistance. The longer that we give, the broader the antibiotic cover that we give, we are increasing hospital stay. We are increasing antibiotic resistance, and we are increasing antibiotic-associated diarrhea due to Clostridium difficile infections as well. So invariably, the main thing is we have to give appropriate antibiotic for the appropriate duration, just enough duration to kill the bacteria and safeguard the patient. The next factor, what is aware classification? I think time has come to be aware about the aware classification. So what is this aware classification? So there's a place that you can enter this in the antibiotic chart, AWR. What is AWR? So this is given, this is introduced by the College of Microbiology and other professional colleges collectively. And there are 3 groups of antibiotics: access, watch, and reserve. So access group of antibiotics are the safer antibiotics that we must use. Ideally, all the 60% of the antibiotics in the whole hospital should be access group of antibiotics. I'll show you what it is. So watch group antibiotics, we have to be careful using these antibiotics. That these antibiotics should be reviewed by a consultant or a senior medical officer after 48 to 72 hours. Reserve antibiotics, we have to be extremely careful when we are using it, because the watch and reserve group for antibiotics will have more and more resistance. If you use it more, they will become resistant very quickly. So reserve antibiotics ideally should have a written authorization by a consultant microbiologist within 3 days of initiation. So this is the access, watch, and reserve group of antibiotics. You can see in the watch group of antibiotic, ceftriaxone, quinolone, ciprofloxacin, meropenem, piptas. So these are the watch group of antibiotics. We have to be watchful because they will become resistant soon. Reserve group of antibiotics such as colistin, linezolid, levofloxacin that we commonly use, they are at very high risk of having antibiotic resistance. So we have to be extremely careful when using these antibiotics. Then this all the things that we discuss, antibiotic chart, antimicrobial resistance, and our idea, our motivation to fight antibiotic resistance boils down to 2 words: antibiotic stewardship. So antibiotic stewardship is an initiative that is practiced in all other countries. So our country has also started this to safeguard use of antibiotics. Stewardship means the careful, responsible management of something entrusted to one's care. So I think if we call the nursing profession also, it's basically a stewardship. We are safeguarding patients' care. So there should be antibiotic stewards who are safeguarding antibiotic usage. So antibiotic stewardship means optimal selection of antibiotics, optimum dosing, optimum duration, resulting in best clinical outcome and minimizing the harm, improving the antimicrobial prescription, minimizing the subsequent resistance. So this is antibiotic stewardship, and it will improve the hospital mortality and reduce the hospital stay and the cost as well. So there are certain charts which are there. So there is 30 seconds more. I'll quickly go through it. So you can see this chart, how the demography is mentioned. There's a penicillin allergy in this patient, if you can see, but somebody is trying to give co-amoxiclav in this patient. So we have to understand you cannot give that because there's a penicillin allergy in this patient. And there's another chart here. So you can document surgical prophylaxis in this patient. So even if it is one dose, you have to document this because for auditing purposes, these are very important. Another chart here, the antibiotics has been continued. If you can see that without a doctor's review. So we have to encourage doctors to do the proper review of these patients' antibiotic choices. So I will stop there. Thank you so much.